What's up, guys? Joel here with the Shift Brief. Today I am joined by my colleague and good friend, Mr. Stephen Burke. Steve and I have been working together for approximately 5 years now.
Yep.
Steve's background, he is a registered nurse. He's a critical care nurse, as well as working as a flight nurse in the same organization as me. Go ahead and introduce yourself, Stephen.
Well, that was a good one.
Yeah.
What's
your
that's
background,
about
I guess?
it. I was born 8 pounds 6 ounces. My name is Stephen Burke. I'm from Cape Breton. Grew up in Cape Breton, did my nursing training in Cape Breton, and then moved up to the big city of Halifax, where I started my nursing career. I've been in neurosurgery for 17 years.
Neurosurgery, yeah.
Different aspects.
That's awesome.
And then been flying for the last 8. Yep.
So you are our neuro guy.
I am a neuro person. I am a neuro person. Worked in neurosurgery on the floor, and I worked in the intermediate care unit, and worked in ICUs in a neuro capacity.
That's awesome.
For the last long time.
Yeah.
Which I didn't know what neurosurgery was before I came to Halifax. I had never worked a placement or anything in neuro ever. And then my first job was in neurosurgery, where we take care of traumatic brain injuries, subarachnoid hemorrhages, closed head injuries, spinal cord fractures, spinal cord injuries, and then the weird and wonderfuls like neurology, endocrinology. So it's a big it's like a dumping ground for all that is neuro. And a lot of the time when it was the sicker neurology patients would always come to us because they required a lot more care. And so we do actually, and that's the thing, we actually do end up dealing a lot with like endocrinology especially, and med-onc, rad-onc. We deal with all those services.
A mixed bag of everything.
Yeah,
wow,
great.
That's impressive. It's pretty busy then.
It is.
Yeah.
And
So,
a little bit crazy. Which is perfect for me.
Goes with neurology. Yeah. Today, this episode, I guess we can call them episodes now because we have things going on.
It's an episode.
It is an episode. This episode is going to be just discussing neurology with Stephen. We now have his background. We have introductions times 2.
Yes. Yeah. So well introduced.
Yeah, well introduced. Yeah. So I'm just gonna fire out some questions, and we'll just discuss them. And really, this the shift brief is growing. It's coming from the ground up. So we're discussing, everything from primary care, paramedic student level up to critical care. Mm-hmm. It's primarily paramedic based, but certainly nursing and paramedicine definitely overlapping in many ways. Yeah. So some of the things that we find overlap, obviously in patient care, is neurology. We're talking about strokes, we're talking about seizures and things like that. So why don't we talk about strokes for a couple minutes? I guess, can you explain what a stroke is to people that might not be familiar with what it is? I know there's a couple different kinds.
Yeah. So I mean, I think the one that we deal with the most is, the one that everybody's familiar with is an ischemic stroke. Mm-hmm. Those are our patients that are like time sensitive, they're time dependent, and they're the ones that we're flying for to get them to a stroke center as fast as they can, because just like the heart, and that time is muscle, time is brain as well. So the sooner we can get that ischemic clot or whatever that debris is that's blocking the blood flow through to get the circulation to that part of the brain, the quicker we can get rid of that, the better chance that the patient's going to have.
So you can say an ischemic stroke is to the brain what a heart attack is to the heart. Yeah, it's a clot. Yeah. It's affecting the blood supply.
Yep.
And damaging that tissue beyond that clot.
Yep. In that instance, for sure. Yeah.
Okay. What about the other kinds?
And then the other kinds that we have are hemorrhagic strokes.
Yeah.
The one that we see a lot of the time is going to be a hypertensive bleed. So patient has uncontrolled hypertension, or patient has been weaned off of their hypertensive medications over the last couple of days, hasn't had a follow-up appointment, doesn't realize that their blood pressure's through the roof, and then they tend to have what they call a hypertensive bleed, or you could call it a hemorrhagic stroke.
Right.
And that's basically the reason that they differentiate between an ischemic stroke and a hemorrhagic stroke, is because it's not from a trauma, it's from a blood vessel that
Right.
has busted.
Yeah.
And it's busted under the pressure of the hypertension. There's certain areas of the brain that you'll see most frequently, like if you'll see a lot of hypertensive bleeds within like the basal ganglia, which kind of sits like towards the back of the brain.
Mm-hmm.
And the reason is because within that basal ganglia there's like a triangle of vessels that are actually quite thin,
Okay.
and a lot thinner than a lot of the other vessels in the brain.
Mm-hmm.
And so hypertensive bleeds kind of tend to happen. Not
Yeah.
that they're all going to happen there, but most of the ones that you kind of will see if you kind of dig into it, which I'm a nerd, so I like to dig into that stuff. Where it is, when it like it will be kind of within that basal ganglion area.
Okay.
Um, and those patients can all present differently, and that's the crazy thing about strokes in the brain, is that like depending on what vessel you have occluded, you're going to see symptoms that are different. So that's when you can kind of, when you start assessing patients and you kind of see, oh, this guy is aphasic and his personality is off. And
What do you mean by phasic? What's a phasic for the
so
folks
yeah,
that may
so
not
when
be
you
familiar with it?
yeah, when you talk about like neuro assessment, we talk about like some core things that we're assessing, because really what we're trying to do is figure out like the basic neurological function that's happening, right? You have to put everybody on the same scale.
Mm-hmm.
And that same scale, I mean, there's a lot of different assessment tools, and especially for stroke. I mean, Cincinnati is one of them that we don't really use a lot, and we don't, but it's definitely used throughout Canada.
Yeah.
GCS is kind of what we really use for neurological assessment.
Sure.
Um,
And we're going to jump into those here in a couple
yeah,
minutes for sure.
yeah. So creating a baseline, and through those assessments, starting to make like, oh, like patient A had A, B, and C as symptoms,
Mm-hmm.
and that's what kind of bleed it was. And then patient
Okay.
B had A, B, and C, and that's what kind of bleed that was.
So you can kind of group them together.
Yeah, you kind of start, as you see these patients and are assessing these patients, and you're hopefully finding out what happens to them after.
Right.
Is
It's definitely a
sometimes
challenge.
sometimes the hard part about paramedicine, for sure. Um, that you start to see, like, you start to group these things together and these symptoms together into like certain areas of the brain that are actually affected.
Yeah, that makes a lot of sense.
Yeah.
We, certainly know there's different areas of the brain control different parts of our body.
Mm-hmm.
So yeah, if you're immersed in it all the time, certainly you would develop a natural habit to be able to group those things together.
So alcoholism is one of those things, and I'm pretty sure it's called Korsakoff syndrome, which is like, because people that have alcoholism or suffer with alcoholism, they have natural kind of brain atrophy, and when your
Mm-hmm.
brain atrophies, it shrinks.
Right.
So what ends up happening is that our brain is like all along our skull, right, and it's held onto our skull, but when the brain starts to shrink,
Mm-hmm.
it starts to tear away from the dura.
Right.
And then what we end up getting actually is a subdural hematoma. So a lot of patients that suffer with alcoholism can end up with spontaneous subdural hematomas.
Right.
And yeah, we would deal with, so subdural, subarachnoid hemorrhages, all different kinds of bleeds that can happen within the brain. And basically all the word is trying to tell you is what layer is it located in.
Okay. Yeah.
So alcohol, people that suffer with alcoholism do tend to get spontaneous subdural hematomas that need to be
Absolutely.
evacuated.
Going to come back to a few things you touched on. So Cincinnati Stroke Scale, GCS.
Yeah.
We'll just talk about those for a minute and kind of break them down for people.
Yeah,
so
absolutely.
Cincinnati Stroke Scale, as we know, speech, facial droop, and arm drift.
Yeah.
Talk about those for a couple of minutes and kind of what they mean to you. I know 1 out of 3 findings versus 3 out of 3, the significance. What does that speak to you if somebody has maybe one finding, so just let's say a garbled speech, but they have no arm drift, they have no facial droop? So a positive Cincinnati with that one finding. How sensitive do you think that is?
I mean, GCS and Cincinnati Stroke Scale, and a lot of the things in medicine are operator dependent, and assessor dependent.
Yeah.
So I'm not. we don't really use the Cincinnati Stroke Scale a lot in the hospital,
Yeah.
but it is an excellent tool because at least it brings in some of the cranial nerves.
Okay.
Yeah, because GCS is kind of like we're just trying to look at basic function. So we're looking at, eye opening, we're looking at verbal response, we're looking at motor response. And being able to do that really well and understand how that works is actually really important.
Right.
And even if we stop there and we get a good GCS and it's a good reliable number,
Yeah.
that tells us so much. Um, and I mean, I've been through this with nurses a billion times before, is that like you need to know what does classify as a localizing response in your motor response, what does classify as a incomprehensible sounds. And so you have to look into each one of those little things. And patients can be oriented but still have a GCS of 11T because they're intubated or
Yeah.
they're trached, or so there's a lot of variations on a GCS scale, which is why we say that it's not super reliable, but it is still an important number that we use every day, because it gives us at least an idea of what we're dealing with,
Right.
and for us going into a scenario.
So just to break it down for the people that don't
Yeah.
know what a GCS
Yeah.
is, so GCS is it's a Glasgow Coma Scale,
Yeah.
and it is a widely utilized tool to uh, essentially evaluate a person's level of consciousness and responsiveness, their ability to follow commands and look at you and talk to you and move all their limbs and things. And it's based out of a score of 15. In those three categories. If you get the worst in each category, you get a score of 3.
Yeah.
So a 1 for eye opening, a 1 for voice, and a 1 for motor. So a GCS of 3 is the absolute worst you can have, and a GCS of 15 being the best you can have.
And we'll put the prompt up right here.
Yeah, that's right.
Right here.
Right here. Yeah, well, you're welcome to look at that and break it down on your own. But I do encourage you in your practice, if you're a paramedic, healthcare provider, or whatever you're doing, when you provide a GCS, provide a breakdown of what that GCS is. So whoever you're giving handoff to or report to, they understand where they're losing their points and what that means to them.
Yeah, especially prior to, and develop, like, depending on where you are in your practice, I guess, like prior to an intubation.
Yeah.
Because once a patient is intubated, we don't have the ability to really, we can assess them, but it's not going to be as good of an assessment or as good of a number or a predictable number as if they weren't intubated. So it is really important that if, like for us, if we come on scene, my first question is, well, what was your best GCS prior to the intubation? Right. So, because that's really going to that can predict a lot of morbidity, mortality as well as the patient goes through their hospital stay.
So shifting gears a little bit, I'm still talking about strokes and GCS and Cincinnati. We know not everything that looks like a stroke is a stroke. One of the first ones that comes to mind for me is a patient experiencing a diabetic emergency, so hypoglycemia.
Yeah, absolutely.
Their sugars are low, they're altered, they have slurred speech, stuff like that. What are some other stroke mimics you could think of?
Intoxication, for sure. Not necessarily, because not all strokes are going to appear the same.
Right.
So we look at face, we look at limb movement, we look at, like, this hemiparesis, that stereotypical presentation of a stroke.
Yep.
But
so paralyzed on one side,
yeah,
can't talk,
exactly.
Facial droop.
Yeah. And you might not be able to assess a facial droop on some patients. Like some patients just their anatomy's off and it's weird, and sometimes they're not going to obey the command.
Why do you keep pointing at me when you're
because you're stubborn. That's why, because you're stubborn. But they might not lopsided. No, okay. Not right yet. I mean, you guys will most of your head is out of frame. Yeah. So yeah, mimickers can be I mean, a head injury, intoxication, you know,
Yeah,
not really. Yeah.
intoxication. That's a
Yeah.
good one.
Yeah. That's usually what we end up seeing on scene
Yeah,
is that. Um,
we see a lot of Bell's palsy
yeah. Bell's
pre-hospitally.
palsy
That's another good one.
for sure.
Yeah.
Yeah.
Okay. It's pretty.
Some of the weird and wonderfuls. Yeah. I mean, Bell's palsy would probably be in one of your weird and wonderfuls.
Yeah. If you were to take the average paramedic and think about their neuro assessment that they're doing, so if everybody be well versed in the Cincinnati stroke scale and
Mm-hmm.
assessing a patient's level of mentation, their GCS. Hopefully, we know that off by heart. Their gait, checking pupils, things like that.
Mm-hmm.
If you had one thing in your background as a neurosurgeon nurse
Mm-hmm.
that you would suggest to add to a paramedic to put in their toolbox for assessment, what would you say get better at assessing, or add this to your toolbox, or check it out, or look it up?
Mm-hmm. That's a really good question.
And if you can't think of one, then maybe just jump into how you would do a neurological assessment, and people could pick up some pointers from that. So if you receive a neuro patient or CVA patient, how would you proceed with a neuro exam on them?
Yeah, I mean, for me, a neuro assessment starts at the door. Like a neuro assessment isn't necessarily me with my hands on the patient.
Mm-hmm.
A lot of the time when I start to assess somebody, if I'm assessing their neuro status, I'm just watching them for a little while. I want to see how they're interacting with the world a little bit.
Mm-hmm.
Um, and I think that that can actually tell you a lot about what you think you're going to find in your GCS. So I think um, that's why neuro is usually not like it's not a quick assessment a lot of the time. Like you're kind of constantly watching people and thinking about a neuro assessment.
Mm-hmm.
Um, like for example, we picked up a patient and like reported low GCS is 7, need to be intubated. But when you walk in, sure, he's not speaking and he's not obeying commands, but his eyes are wide open and he's looking around the room and he's like shifting from like right to left. And you're like, okay, well, this isn't, I mean, GCS of 7,
Mm-hmm.
we'd intubate them.
Right.
Less than 8, you
Right.
intubate. But that's why the scale is only so good, because you get there and you look at him and you're like, oh no, wait, like he's looking around, he's interacting with me, he's tracking. So it's like there's something's not adding up here. So
Mm-hmm.
that's telling you more information. You might not know what's happening, and you don't need to know what's happening.
Mm-hmm.
Your job is to be able to communicate what you saw to the people that you're bringing them to.
Right.
Um, so I would say that there's no like one thing. I think that it's always just be looking at your patient and observing your patient and thinking about what they're doing neurologically.
And how that applies to
Yeah, and you
the.
already talked about like, limb assessment and pupils and like, you're watching for nystagmus. You're watching, do they turn their head all the way to the right side, or are they
Mm-hmm.
only turning their head to the left?
Right.
Is this a neglect that we're not picking up because everybody's approaching them from the left side,
Mm-hmm.
and then, okay, well, now you've just discovered, okay, he will not turn his head to the right at all. And you've just discovered, now I have a right-sided neglect.
Right.
So what's causing that? And
Yeah, that's a good point.
yeah.
We all tend to approach the patient from the same side.
Hmm.
Paramedics are notorious for saying we're going to come at you from all angles, but oftentimes that's still
Still the same
still
angle.
the same side, still the same
Yeah.
angle. So yeah, making sure you're going left and right. We've covered pretty well the different types of strokes, ischemic versus hemorrhagic. We've talked about some very basic ways to assess them. Talked a bit about the pathophysiology there. Let's talk about treatment for them for a couple of minutes. So pre-hospitally, specifically on the ground ambulance, when it comes to picking up a patient that you think is having a stroke, it's pretty basic care. Stroke team activations, if you're the service that you have offers such a service. So at the tertiary care center, your stroke center, you can activate that stroke service. But pre-hospitally, it's really ABCs. Certainly monitoring that airway. That's going to kind of be one of the biggest issues for the ground paramedics, is taking care of that airway, because obviously seizure, coma, death. That's
Yep.
a real thing that happens. So have your suction handy, have oxygen handy, readily available. Make sure your tanks are full at shift start. You're going to get IV access in case they need to use dye in the CT scanner,
Yep.
or they elect to use dye. And my experience for the ischemic strokes is they're generally pretty stable on transport to the hospital.
Yeah.
The ones that always gave me a bit of a pucker factor pre-hospital were the ones that I thought was a hemorrhagic stroke.
Yeah.
They had a recent history of a fall, or we're talking about that sudden thunderclap headache that these patients experience.
Mm-hmm.
And all of a sudden we're starting to trend down that route of Cushing's triad. So, you're widening pulse pressure with hypertension, your bradycardia, your abnormal or Kussmaul's respirations. And those patients will notoriously projectile vomit, and they'll seize and they'll clench and they'll go into cardiac arrest. So those are the ones that kind of get me very worried pre-hospitally. So aside from, let's talk about the ischemic stroke for a minute. Aside from monitoring and managing their ABCs, getting access, keeping a close eye on obviously their airway, their heart rate, all those things, checking the sugar, make sure they're not hypoglycemic.
Absolutely.
Looking for those CVA mimics. Anything you would offer for treatment-wise pre-hospital, or anything that's important to think about in those ischemic strokes specifically?
I mean, you've just covered it.
Yeah.
I mean, the only thing that I can really add to that is emotional support for the person, if you're able to give it.
Yeah,
I
that's
mean,
a great one, actually.
They're
It's
having
gonna be terrifying.
They're having an absolute meltdown underneath whatever facade they're putting up for you.
Yeah.
Everybody in the general public knows the signs and symptoms of a basic stroke, and when it starts to happen to you, there's nothing you can do about it
because you still know it.
Because you still know, you've seen the commercials,
right?
You've watched the podcast, you've watched the shift brief.
That's right.
Right?
You've learned how to evaluate
exactly,
GCS.
Exactly. Right here. So I think like emotional support for the person is really important. You're always going to have to worry about all of those medical things that you just discussed. The difference between somebody that is good at it and somebody that is elite at it is that they're able to maintain those thought processes in their head while still providing an emotionally supportive care.
Right.
And that's to a family, that's to a family member, that's to the patient themselves. Explain to them what is going to happen, because we've taken them into emerge so many times, prep them for what is about to happen, just to get them into the mindset of, okay, this is happening and I need to step up to this plate right now to get this done.
I think emotional intelligence could be its own chapter, its own category
100%.
in healthcare for sure.
Yeah.
Some people are really good at it and born with that kind of stuff. And some people have to work really hard.
A lot of it though, that comes from experience, that comes from watching guys like you that have been doing it for so many years, and how you interact with patients and how you interact with families. Like, you just watch that, and if it works and it provides that emotional support, you just take that and you just put it in your little toolbox, and you're like, that is the exact conversation that I'm going to have with somebody when this starts happening, when you're on your own. Like, my entire nursing practice is just based on things that I've observed from people that have done it around me for 17 years.
Mentors. We're all fortunate to have some good ones. We've all had some bad ones.
But, absolutely.
Hopefully more good than bad.
Yeah. You kind of, you learn a lot from the bad ones too.
It's true.
You do. You get to decide what you want to add to your practice and what you want to throw away from what your practice is going to be, because it's going to be yours.
Right.
But it's going to be made up of a lot of the things that you've observed over your years.
And that's a good way of looking at it. It is going to be yours. And at the end of the day, you're responsible for your demeanor and your treatment in that moment. You're certainly responsible for your license.
Yeah. 100%.
But that person experiencing that emergency is relying on you to have ownership of the skill set
Yeah.
that you're bringing to them.
And that's the thing. They're not going to remember how much Levophed they were on, but they are going to remember if you shaved their nose, or if like that's. I only say it because that is exactly something that has happened to me.
I believe it.
So those are the things that patients will. Anyway, so what I'm saying is you've discussed perfectly all of the. Hyperglycemia is definitely one of them that you have to watch for. It has been proven people that are hyperglycemic and having strokes don't do as well. So hyperglycemia, you want to keep them thermic.
And we're still talking about the ischemic strokes.
Ischemic strokes.
Yeah. It's a little bit challenging, certainly here in this province, to deal with hyperglycemia. Pre-hospitally.
Absolutely.
So fluid admin were appropriate for sure. Saline is what's carried on the ambulance, but hyperglycemia, certainly a good one to consider.
Just make sure you have a number.
Yeah.
Make sure when you roll through that door, you're like, he's got a glucose of 16.
Yeah.
So
here you go.
Absolutely. And then I go, thank you very much. And I grab the insulin syringe, that's
right.
It's the transfer of care. Like the more information you have for me coming in, the quicker I can do my job, and the quicker I can get treatments on the way. And I'm going to recheck the glucose anyway, but I'm probably going to be grabbing for the Humulin R and bringing it in with me right before I check it.
Right.
Because I know I need to get that down.
Right. So let's talk about hemorrhagic strokes and how their care would be a little bit different from ischemic stroke. So pre-hospitally, once again, ground ambulance paramedics, ABC is super important. This one we talked very briefly about that seizure, coma, death. I've seen it countless times where those patients have that sudden herniation, raised intracranial pressure. They start to seize, they start to vomit. You have an insanely difficult time managing their airway, and they have a cardiac arrest in the field because
usually
it's very fast. PEA. So
when they let go, they let go.
So timely transport for those guys. I would say to anybody that's doing this, I just realized I'm 3/4 of the way out of the frame here. I would say to anybody that's doing this,
I have to just remember I'm actually on camera.
I would say to anybody that's doing this pre-hospitally is make sure that you're not delaying transport for anything that's not crucial. So
get your IV access on the way.
IV access on the way. I've always been a big proponent of that. Is the mentors I had kind of coming up through my paramedic career have almost always told me get really good at starting an ambulance or starting an IV going 80 kilometers an hour backwards, because there's almost never a reason to stay there unless you're fixing hypoglycemia or maybe your patient's seizing, you need to give them some benzos and things like that. But 95% of the time you don't need to delay transport to start an IV. So get the big stuff that matters out of the way really quickly, and then expedite transport to your stroke center. The care for a hemorrhagic stroke, then, how would that be different from an ischemic stroke, or is it the same?
I think it's pretty similar.
Blood pressure control.
I would say blood pressure control. You're worried in both. You don't want to. And I mean, this is again probably, a little bit, but you want to get them there as fast as you can. That's the point. You want to do your ABCs. You want to have a glucose when they get there. We don't want to overly lower their blood pressure. And we don't want to do that because the brain is still going to need to use collateral circulation in order to get blood flow and get oxygen to the parts of the brain that it can. So it needs to overcome.
Right. So that's that whole cerebral perfusion pressure.
Exactly. Yeah.
I'm trying to remember it. And I think if I go back to the school days, it's mean arterial pressure, subtract ICP.
Yeah. And we'll never have, pressure. So it's your intracranial pressure that's going to minus from your mean arterial pressure is going to give you what your cerebral perfusion pressure is.
Right.
So we don't have a way to measure intracranial pressure in the pre-hospital environment. Exactly. We do in the hospital.
Right.
We throw an ICP Express or an EVD in the brain, and we can get a pressure, and it's transduced, and we can start to trend what that is, and we can start to push pressure in order to get a proper.
But to your point of
perfusion
making sure that we don't drop the blood pressure too much,
Yeah.
the reason being is
You
because
don't want to lower the central perfusion pressure.
yeah, exactly.
Yeah. So we usually say that we don't really want to lower that blood pressure like greater than 25% of what the patient's baseline blood pressure is. So that's kind of where you try and draw a line. For a hemorrhagic one pre-hospitally, you're still not going to really know.
Yep.
You're going to gather your history, you're going to gather your vitals and how the patient presented,
right,
and try and get a really good case on, oh, I wonder what this is, right, based on all that information that you're gathering.
So it kind of brings us back, we're talking critical care right down to the primary care student level. You're working in the neurosurge unit. We work in a flight critical care environment. But really, if I were to summarize all the information that we just put out there for everybody, what we're saying is be good at the basic stuff.
It's what it all comes kind of down to. Like if you need to have your assessment and the ability to gather information and present a patient,
right,
is detrimental to how somebody that you're giving that patient to is going to perceive what the diagnosis is.
Yeah.
So gathering that information and a good med history, and because you bring patient in, we don't have a med history, how are we to assume that they're on blood thinners, and then they deteriorate and they emerge?
Yep.
And then we're like, why did they deteriorate so fast? And then
find out they're anticoagulated.
Yeah. And we could have reversed it, or we could have tried to reverse it, if it was something that was reversible.
Yeah.
To try and give them a little bit more time so that we can get them to intervention,
Yeah.
But that's the whole thing about it, is that you have to be really good at the basics.
Yep.
You have to know anatomy, you have to know physiology, and you have to know assessment, and be able to gather a history and gather a story quickly.
Yes.
Because
expedited
you gotta go. You gotta go.
Definitive care, right?
Yeah,
we talk about that stay and play or load and go situation.
Yeah.
That's a phrase all paramedics, but certainly new ones are familiar with. Is it stay and play or load and go?
Definitely.
And these are load and go situations.
These are load and go.
You are not going to fix that patient's problem there in their living room. So unless you have to do something that's immediately life-saving, it's time to get out of there.
Yeah.
It's not just time to stay and chat and make jokes, which I love to do.
Yep.
But
You're
I've gotten a lot.
good at it.
I've gotten a lot better at, knowing when, placing them appropriately.
Absolutely.
I think we're going to wrap it up for the stroke conversation. That was pretty in depth.
That was a lot.
Yeah, I was thinking we were just going to go for 5 or 6 minutes, but I'm
as
sure
somebody who doesn't deal with a lot of strokes, that was a lot.
Yeah, that was a lot. So that was
subarachnoid hemorrhages.
Yeah,
let's go.
Anything else you would throw out there before kind of in closing, or do you think that's suffice?
Watch, follow, and subscribe.
The shift brief. All right.